So the next talk is multimodality imaging of digital mammography. So I have a lot of cases to show you instead of, because I know that you're tired of the whole day. So we will see a lot of cases that will also have ultrasound. So we will refresh the ultrasound imaging that Dinah has told you. So when the digital mammography in 2005, there was this DMIS trial in the United States. The overall diagnostic accuracy of digital and film mammography as a means of screening for breast cancer was similar in that study. And so this showed two things. One, that because the digital mammography didn't have as good resolution as the screen film mammography, but this showed that resolution, even with that resolution, it had the same result. But with the patients who were younger than 50 years, it had a better result. The digital mammogram showed better result than screen film mammography. So this was not. This was the beginning, but with the digital mammography, we had this opportunity to do different things like tomosynthesis, contrast-enhanced mammography, stereotaxic tomobiopsy, computer-aided detection, and artificial intelligence. That was none of them was able. We were able to do with screen film mammography. So digital mammography brought us to a different era. Well, breast imaging has three main imaging systems. It's X-ray, ultrasound, and MRI, and they have different modalities or different advantages. And so we can use the imaging-guided biopsies under these modalities. And so we have a lot of options to when we have the diagnostic or screening patient. What is the role of mammography in multimodality imaging? It's major screening. It's the major screening tool particularly for the patients, for the women older than 40 years. It's a major role in diagnostic workup and differentiating the lesions, finding the associating findings like calcifications. It's the only modality that can show the calcifications, which is the indicator of DCIS most of the time. Architectural distortions, retractions, and differentiating findings other than mass. Also, you can use it as a second look modality for MR detected lesions. Although ultrasound is very effective in that, you can use also mammogram in second look. You can use it's mostly used for monitoring breast cancer patients, and it's also used as a guiding modality for image-guided biopsies, particularly for calcifications and architectural distortions, which may not be seen with ultrasound. And also, tomosynthesis-only detected lesions, we have difficulties in detecting them or finding them under ultrasound, so we can do the biopsies. The challenges in mammography are the dense breast tissue, and the calcifications are difficult to identify, and architectural distortions and asymmetries. When we see these three lesions, we cannot find them under ultrasound, so it's difficult to differentiate them, make a differential diagnosis. For the breast tissue, we have four categories depending on the Biarritz system or the ACR system. It's from A to D. The D is the densest breast. It's all dense. You see on the right-hand side of yours, it's all white. So half of according to ACR, half of the population has these dense breasts like C and D breasts. In my daily routine, it's 60%. In my country, it's 42%, and it means that almost half of the mammograms that you will see are dense. So what density means in mammography? It means that it is the half of the patients, and when the sensitivity is very high for ACR-A and B breast, it is very low for the DC. For the dense breast, it's like 30%, 30-40%. And the odds for interval cancers is very high for the D breast when compared to fatty breasts. And false positive findings are high. So this is a dense breast where I can say that she has cancer or she has a mass for 2 centimeters. Can you see it on MLOs there? I don't think that you can find it. Or can you see on the CCs? It's 2 centimeters speculated mass. Okay, let me show the tomosynthesis. That's the lesion. It's a 2 centimeters speculated mass that we see nothing on the MLO 2D view. So tomosynthesis helps us a lot in sensitivity, for the sensitivity of the screening in dense breast. Here you see nothing, but on the other hand, the tomosynthesis view shows you a very small speculated mass. This is a 56-year-old woman screening mammogram. She had a history of colon cancer 5 years ago, and she didn't have a dense breast. It was almost A-type breast. And so what tomosynthesis gives us, not only increasing the sensitivity, but also in diagnostic imaging, it helps us a lot. In this case, we will see it. Here we see a lesion which looks like a speculated mass of 5 millimeters. And here on the MLOs, we see on the left side 2 lesions, and we cannot decide which lesion was on the CC mammogram. So we had the tomosynthesis view of the same patient. When you look, this is the speculated mass. You see the speculations, but on the other hand, this lesion is not a real lesion. It blends with the fibroglandular tissue. So even it is a B-type, or you could call it an A-type breast, tomosynthesis helps us in not recalling those patients who has lesions. Here is the spot mammogram. Here you see the speculated mass better. So you can see the view preview. It's the 2D, synthetic 2D image, and on the left side it is the tomosynthesis image. So with the tomosynthesis, the speculation is better seen. So of course, when you see a lesion, you would find it on ultrasound to do the biopsy and to delineate better on ultrasound, because ultrasound has better resolution and gives more information about these lesions. Here we have the elastogram. It shows, in my practice, I use red for the stiffness, and in some practices it's blue, so you would always check here. If it's, you see it is the stiff, it is the soft one. And you can also, as this morning it was told, you can also calculate the ratio, stiffness ratio, and find. Here is another case that you see nothing on the 2D mammogram, but on tomoslice you see a speculated mass on 12 o'clock. It looks like a 12 o'clock. This is one of them. The first one is the slice. The other one is the slab. What is the difference between the tomoslice and tomoslab? Our tomoslices are 0.5 millimeter thickness, and the slabs are 5 millimeter thickness. Sometimes slabs helps us to show the structure of the masses, and most of the time it shows calcifications better. So we search both of them. And here is the automated ultrasound. In most of our cases, for screening and for diagnostic purposes, first we use the automated breast ultrasound because the coronal images gives a lot of information. Then if it's a diagnostic case, then we go on with the handheld ultrasound, but we first see it on automated ultrasound. This is the coronal image on automated ultrasound, and this is the transverse image on the automated ultrasound. So it looks like a malignant lesion that ultrasound gives you. As I told, it has a better resolution, gives you more information about the lesion. Here are the 4 mass definitions 3 mass definitions in BI-RADS. It was before 2013, it was 4, but now they have also called the lobulated mass as oval masses. So we have round, oval, or irregular masses. Round masses can be malignant, ovals are mostly benign, and irregular ones are mostly malignant. So these are the margins that you can call. If it's circumscribed, it's mostly benign, but if it's speculated or indistinct, it means that it's malignant and it's an infiltrating lesion. To call a lesion benign or well circumscribed, you must see at least 75% of the lesion clearly. This is a 40-year-old woman. It's a screening mammogram. It's a B to C type, and so maybe there is not much you see here, but maybe there is some asymmetry here. But with the tomosynthesis, you can easily see here, it is a movie that moves through the slices. Here you see the speculated mass appearing, and here is the speculated mass of the slice that the lesion is best seen. And here is the automated ultrasound image, the coronal image, which shows us the retraction of a black hole, which is a sign of a malignant lesion most of the time. And this is the transverse image of the automated breast ultrasound with malignant features like it doesn't have a shape and the margins are not good. So you can see also the handheld ultrasound findings, and there we see the elastography, it's stiff, and this is shear wave elastography, and this is the Doppler imaging that it shows vascularity which goes through directly to the mass. And this is the MR image of the same lesion. And here on the ultrasound, we saw the speculations and the retractions and some edema around the lesion, which are important ultrasound associating findings. This is a 53-year-old woman. She has a history of previous malignant tumor surgery on the right breast. And there is a lesion here. It's round, it's well circumscribed, it's very black, it's hypoechoic, but on Doppler we do not see any vascularity, and on elastography it looks like soft. So what do you think it is? Well, she was examined somewhere else, and someone else has seen this, and they ordered a biopsy because they thought that it was the relapse of the tumor at the tumor bed. But it's clearly, when you look at the mammogram, it's clearly an oil cyst, because you see in the middle it is black, so the black is fat. And 1 year after this, on 2017, the same patient, she had something here on MLO and on CCs that was overlooked at that time. But however, on tomosynthesis, you can easily see that these lesions are not well circumscribed, they are speculated. And the handheld ultrasound was normal, as she had a very fatty breast. These lesions were suspicious, and they preferred to do the handheld ultrasound, and it was normal. So they sent the patient home. So would you do it if you have suspicious mammography findings, and if you cannot find it on ultrasound, it doesn't mean that it does not exist. Sometimes in fatty breasts, it's very difficult to find the lesion that you see on mammogram. So if you see it on mammogram, and if you are sure that it has some suspicious findings, then you should go on. You should do a biopsy under mammogram, or you should do an MRI. So next year, there it is. It's a little bit larger than before when you compare these. And still they have speculated margins. This is the 2D image, and this is the tomosynthesis images. No, this is the 2017, sorry. And so they have enlarged. Here, 2017 and 2018, tomosynthesis images. And in 2018, we had the automated breast ultrasound, and we have seen both lesions on both coronals. And you see on coronals, they look like black holes with retractions or speculated margins. And here on ultrasound, on the transverse images of the same ABUS, this one, the second one, looks like it has a taller than wide. It's non-parallel, but the first one here, it is parallel, so it looks like benign. But however, coronal images are suspicious and the mammogram images suspicious. So would you do biopsy to both of them, or just one which was not parallel? So you would do both of them, because with the other modalities you have suspicious findings. Here, this is the handheld ultrasound finding of the same image, which is not parallel. This is the second one. And with the Doppler finding, this has Doppler, it has no vasculature. So if you, in the morning there was this discussion that if we have elastography negative, or we might have elastography that shows that the lesion is soft, or we might have Doppler sign without any vasculature. But if we have mammography findings or some grayscale ultrasound findings which are suspicious, we should do the biopsy. And this is a 43-year-old woman with multiple breast cysts. She has screening mammograms. She has very dense breasts, so 2D mammogram won't help in these cases. So you would have tomosynthesis at least. And the tomosynthesis shows a mass here, which is speculated. Here it is enlarged. You see that it has speculated margins. And the ultrasound, she has a lot of cysts on coronal view. We see here the cyst, but there is something else here which doesn't look like cyst. It may be a complicated cyst, but it doesn't look like well. And this is the handheld ultrasound finding of the same lesion, which has posterior acoustic features, which is enhancement, and it may look like complicated cyst. But when you go back to the mammogram, it's sure that it doesn't have good margins. It doesn't have circumscribed margins. It has speculated margins. So when you combine the multimodality findings, mammogram says it's quite malignant, and ultrasound says it's suspicious, so you should do the biopsy. And this is the MRI finding of the same patient, which shows that it's malignant. So this is an invasive cancer, a luminal by B type, and 73-year-old woman with all fatty breast, which is a type E breast. Here, would you do tomosynthesis? Normally they don't, but it helps when you have findings. Here there is a lesion where this is a screening mammogram. Then you should recall this patient for this lesion to make more views for spot mammograms. But if you have the tomosynthetic images, then you will see that it does not have good margins. But this patient has been overlooked for 2 years because the lesion was in the lower part of the breast, where this triangle is very important. In this triangle, most of the lesions can be overlooked. You can miss them, and this is one of the triangles that you should keep an eye on it. So this was particularly on 2019, the lesion showed speculated margins here on tomosynthesis images. Here, when you compare to compared to 2018, it's getting larger. So it's a developing lesion. It warrants the biopsy. But however, the ultrasound finding was a parallel lesion, parallel oval lesion, and so the radiologist who has seen the ultrasound called it benign. But what she couldn't see was the speculated margins on the tomosynthesis images of this lesion on mammogram. So when you are using multimodalities, just keep the most malignant signs over the benign signs that you see in other modalities. So maybe this ultrasound finding can be a benign finding, but the mammogram shows that it's malignant. However, on elastography, it shows stiffness. It's a 50-year-old woman. Screening mammogram shows a mass on the right upper inner quadrant. Here, it's again a type A breast. It's a very small lesion, but when you do the tomosynthesis, you can have the margin information better than the 2D images. And the ABUS image of the coronal image shows that it's a black oval with retractions, and there the transverse image isn't good. And here are the handheld findings that it doesn't have vasculature, but it is stiff on elastogram. A 51-year-old woman, she had breast cancer surgery on the right breast 5 years ago. Here, sorry, it's on the left breast, the surgery was. And this is now the right breast that you have a lesion with speculated margins. It's quite malignant, and also the tomosynthesis shows as well. This spot also shows well. So we should continue on the ultrasound image to do the biopsy with this patient. Again, another screening woman, 46-year-old. Seems normal, right? But it's a C-type breast. But on the MLO, there is a mass, and the mass seems on the tomosynthesis image, it looks, you cannot define all the margins very well. In some cases, even the tomosynthesis can't help you to define the lesion very well. Then this is the coronal image, which shows lobulations. But the lobulation seems more than 3, as Dinah told. More than 3 lobulations should warrant a biopsy. Here it looks lobulated, but we always do handheld ultrasound for these diagnostic cases. And the handheld ultrasound show a parallel lesion with well-circumscribed margins, but it has a vasculature. So we preferred to do the biopsy, and it was not hard on elastogram. It was a fibroadenoma. 38-year-old woman, diagnostic imaging for a lump on the right breast. And so in diagnostic imaging also, we use tomosynthesis all the time, particularly for these cases with denser breast. And here on the right hand, on the right breast, you can easily see a lesion here, and here on the tomosynthesis you can see the speculated mass now coming. It's playing now. You see the slices are coming. Here is the speculated mass, and this is the ABUS image of the coronal image and the transverse ABUS image, and the handheld ultrasound with elastography shows that it's stiff. But in this case, I don't have the good images here. With the ABUS images, we have seen 3 more foci, and we prefer to do the MRI here, and she had a lot of foci. It was a multicentric cancer. 42-year-old woman here. Small calcifications just over the, on 12 o'clock over the nipple here. When we see calcifications, we always perform MRI because MRI gives more information about the calcifications, and it gives more information about their distribution. Sometimes you may not find anything on the MRI, and if you don't find anything on MRI, then you have to rely on your mammographic findings, not on MRI findings. And on ultrasound, we do automated ultrasound in cases we see calcium calcifications. Here we have found a lesion, suspicious lesion, which was far away from the nipple. The area where the calcifications were here, but here it was. And over the nipple, we have seen on the 12 o'clock, we have seen some dilation of the ducts. And on MRI, this is the suspicious lesion that we detected on ABUS, and we have found it on ultrasound. It was one part of the DCIS. It was a large, very large DCIS. Here you see it, but on mammogram it was a very small calcification focus. So MRI helps you to understand the extent of the DCIS in cases of calcifications. That's why we always do use it. So it was easy for us to do the biopsy under ultrasound guidance because ultrasound guidance is cheaper and easier. So we did the ultrasound guidance and we had the result. And so we have 4 different types of calcifications in mammography imaging that are moderate suspicious are heterogeneous and amorphous calcifications. High suspicious are linear branching calcifications and pleomorphic calcifications. So when you're doing MRI in our study, we have found that when it's linear branching or pleomorphic, if you have negative MRI findings, you should do the biopsy. But with the heterogeneous or amorphous calcifications, if you have a negative MRI finding, you may stop, but it depends to your clinical decision. This is a 44-year-old woman. She was having a screening mammogram. Here you see a segmental calcification where you can easily find it on ultrasound here. Dilated ducts here, it's the DCIS, these are the ABUS automated breast ultrasound images, and this is the handheld images, almost identical with the ABUS image, and there you can easily do the biopsy under ultrasound, but be careful, you should take a specimen radiogram of the biopsy you did, and you should show that you had biopsied the calcifications. It was a DCIS. And this is another case with calcifications here. Again, the MRI showed the extent of the lesion. It was larger than seen on mammogram. And so we have found it under ABUS, automated breast ultrasound. And this is the identical image on handheld image that we did the biopsy under ultrasound. And here you see the calcifications on specimen radiograms. You should always do this if you're doing them. This is a case of breast cancer patient. Same, it's the surgery bed. It's a relapse of the disease. And same with the MRI, the extent. You see the extent, and ultrasound you can see the lesion well. And this is the specimen radiogram. So you can do the stereotaxic biopsy under MRI. This is the scout image, and this is the 15-degree images. Tomorrow you will have the opportunity to see this. You have 2 15 degrees images to have the stereotaxic positioning, targeting of the lesion. This is where the needle comes in. We use the upright positioning of the patient with lateral approach of the needle. Here is the needle approach. This is the lateral approach, which is easier in my opinion. But some people prefer the horizontal approach. This is another case where we had retracted calcifications, and always take the specimen mammogram to show the calcifications. Another case here, the calcifications are very small, and this is the SCOT and 15 degrees images, and the needle is in the place, and you do the after the biopsy, you should check the area if you have retracted the calcifications well, and always a specimen mammogram to show that the calcifications are out. This is a very small other case, and same, and the specimen mammogram. So there is another possibility that there is this prone table. It's more easier for the patient. It's more comfortable, I can say, and you do approach horizontally in these cases. Same 15 degrees images, then always take the specimen radiogram. In some cases, lesions cannot be seen on dense breasts. Even on tomosynthesis, it may not help, but there is this asymmetry here. Even the ultrasound may not give much information, but here she has abnormal lymph nodes in the axilla. Then MRI will help you to understand what the lesion is, and this is a lobular cancer. Lobular cancers are most of the time hard to detect on mammograms or on ultrasounds. The best way to show them is the contrast-enhanced MRI. And the last but not the least, the contrast-enhanced mammogram helps us. This is a lesion. It looks like a one lesion here, but with the contrast-enhanced mammogram, you see a lot of lesions. It's a multicentric cancer here. So CSM, a contrast-enhanced mammogram, can detect a lot of lesions and able to detect mammographic occult additional lesions superior to mammogram, and almost it is comparable with the MRI, contrast-enhanced MRI. You can use it for calcifications as well. Here you see some calcifications. And here, the contrast-enhanced mammogram shows us the lesion that the calcifications are contrast-enhancing with contrast material. So with the calcifications also, it helps. It has a good specificity and sensitivity, and it is tolerable, and it can be comparable with MRI, and you can use the MRI BI-RADS lexicon with it. Also, you can use it in problem solving, like in this case. You see a lot of lesions here, but on mammogram, you don't see anything, almost anything. And here is the MRI. It's comparable, but it's not, because MRI has slices, it's not as evident as MRI, but when you compare it with the other breast, you can see a lot of multifocal lesions are there. Also with the neoadjuvant chemotherapy, this is from before the neoadjuvant chemo, and here after the neoadjuvant chemo, and before we didn't have the contrast-enhanced mammogram, but after you can see that it's not, the lesions are smaller but still there. And this is the MRI findings, almost comparable. We also use sometimes for dense breast screening for high-risk patients because they cannot go into MRI. So we prefer to do the contrast-enhanced mammogram, and you can see clearly the breast, although the breast is very dense and dirty with calcifications, so you can clearly send the patient home for 1 year. Another case with a lot of lesions, a lot of cysts you see here. And so also contrast-enhanced mammogram has background enhancement, here you see, but it's not as evident as MRI. So take-home messages: mammograph findings can lead to positive diagnosis even in the absence of apparent lesion, so you should be very careful. Tomosynthesis is very effective in screening and in diagnostic approach, so we always prefer to do the tomosynthesis. And we do we take synthetic views. We do not take any more 2D views. Calcifications, MRI is more into equivocal, more informative in equivocal cases, but in calcifications, adding MRI can help you to understand the extent of the disease. CSM is a new promising tool that might not displace, but that can be used in cases where the patient cannot go under MRI. Thank you for your attention. This is a mammogram of a rose. Thank you very much.